ahead and get started. And if you wanted the talk on unending thrills and spills on amusement park rides, this is the wrong room. A little different subject matter, but we will try to make it, hopefully, a tough subject, somewhat entertaining as well as educational. I like to call it edutainment if I do my job right. Keep you after lunch so you don't fall asleep from a carbohydrate stupor and actually absorb something. But I'm Deacon Brian Collister. I'm a deacon at Our Lady of the Snows Parish here in Reno. I'm also both a practicing physician and an academic physician, and this happens to be one of my areas of interest, morbid as it may be, but certainly a subject matter that's very important to all of us. But before we get started, let's just take a moment and center ourselves and remind ourselves that we are in God's presence. In the name of the Father, and the Son, and the Holy Spirit. Amen. Gracious God, thank you for allowing us to gather as community, as a diocese, to learn about your word, to learn about your will, and to work together to help your kingdom and its presence here on earth. We make this prayer through Christ our Lord. Amen. Amen. All right, so I figure I'll just break the ice right out of the gate. Our society teaches us, of course, that death is something to avoid. Death is something to ignore. Death is something that, and nobody ever gets up in the morning and says, good day to die. Or I think I'm going to die today. That just doesn't happen. But to really get the idea that nobody gets out of here alive, I always loved this definition of life. Life is a noun. It's a sexually transmitted disease which always ends in death. There is currently no known cure. Despite what Cosmopolitan may tell you, ladies, despite what GQ may tell you, gentlemen, nobody gets out of this alive. Now, we, though, compared to non-believers, have a little asterisk on that idea of nobody gets out of this alive. And that is, life is not ended, life is just changed. And I think that's got to be really not only a comforting thing to think about, but also I think something that can guide us to deal with death and dying, whether it's our own death or somebody else's, a loved one, a friend, a student, a coworker, in a much healthier way. Now, at the same time, there's some real practical things that we need to look at in planning for what the end may look like. And it's certainly going to be a lot easier, not only on family and friends, but on yourself when facing your own death, if not only your wishes are known, but if you understand the reality of what's out there, of what can happen to you if you do nothing, if you don't plan, and what inertia, I'll say, looks like in our healthcare community today for people that don't have any instructions on what they want to do. And I think if we fold that all into the perspective of how does that fit with our Catholic faith, how does that fit with Catholic teachings, that can get really tough sometimes to kind of navigate. So over the next 75 minutes or so, we're going to try to take a little whirlwind tour of death and dying in the United States from a Catholic perspective. As a physician, I've worked in the hospital for, 30 years now, and have had experience with death and dying on a daily basis. First thing I'll tell you is you never do get used to it. If you get used to it, something's wrong with you. Every death is unique. Death can be beautiful. You can have a good death, and we're going to talk about that too. But it's still scary because that process, even if we believe in life after death, that process is still something we don't understand. And fear, by definition, fear is the unknown. And we're going to naturally, as human beings, fear something that we don't completely understand. So even though we believe the end point is glorious and eternal life with our Lord, not knowing how that really works can still be a little scary, and it's normal to feel that way. So let's start out by taking a look at death in America and where we are in this day and age. And some of these statistics may surprise you, some of them may not. As of this past year, we're just approaching 2.6 million deaths in the United States every year. Our population is somewhere between 320 and 330 million. So not a huge number, but certainly significant. Life expectancy at birth right now, this is as of 2014, is 78.9 years. Now that's from birth. They keep other statistics. Very interesting. If you're 65 right now, your life expectancy is almost 20 years. So if you've made it to 65, all of a sudden life expectancy is 85. And here's a quiz for you, it might surprise you. What is the fastest growing part of our population? How old?
Baby boomers over 55.
Okay, everyone used to say over 65, that's the standard, the Medicare population. The actual answer, and not that you're wrong, I'm just going to make it more of a subset. The fastest growing part of our population is over 85.
Really?
Over 85. People are living longer and longer, and we're having more people hitting 100 than we ever have. In the year 1900, life expectancy for men was 43 years, for women was 46 years. Now that statistic is a little bit skewed, and Dr. Carlson here can tell you about that because infant mortality was so high, it skewed the whole number down. So basically, if you lived through the first 5 years, if you got to adulthood, you had a good chance of making it to your 50s or 60s, but not 80s, 90s, and 100s like we see now. So what are the leading causes of death? Heart disease, cancer, and stroke. Those rates are dropping. They're not dropping as fast as they were. We had the big drops between about 1980 and a couple of years ago. They're still going down, but at a much slower pace. It's kind of steadying out now. Rates for diabetes, kidney failure, liver disease, and Alzheimer's are all on the rise. So death from those are becoming much more common. And infant mortality is right around 6. It's varied between 5.8 and 6 per 1,000 live births. Interestingly enough, we are not near the top of the civilized world in infant mortality. We're kind of in the middle. We're kind of in the middle. There's about 20 countries or so that are better than us in infant mortality. So, this is part of the reason heart disease, leads death, See the heart attack grill, you can see this home of the double bypass burger, taste worth dying for. That's kind of been our McDonald's mentality, unfortunately. A little bit of a scary thing, but we are getting a little better. I like to say when I look at this, my wife is a dietitian, so she calls me her greatest failure. So this is part of my diet therapy. You can sit and listen. I have to walk and talk. It's a calorie burning thing. So what about the gender gap? We all know that women live longer than men. It's very interesting. With our Western lifestyle, women are catching up to men and the gender gap is narrowing. Women in 1979 lived an average of 8 years longer than men. Now that gap is less than 5 years. Flu and pneumonia rates are rising. 8th leading cause of death, pneumonia now, and it's predominantly in very old people. Anybody have a guess, with all our flu shots and pneumonia shots, why the death rate from pneumonia in old people is rising? Take a wild guess. What?
We're getting one vaccine.
Nope. Nope, that's actually helping to reduce it, but it's still going up. Any guesses? Yes.
They don't go to the doctors.
Actually, it's end-of-life decision-making, very active, deciding not to be in the hospital, not to get IV antibiotics, and specifically due to Alzheimer's disease. With the aging of the population, the rate for Alzheimer's is going way, way up. Most Alzheimer's patients eventually die of aspiration pneumonia. They can't protect their airway, they aspirate, they get pneumonia, we keep them comfortable, and they pass away. So that's the predominant reason. If we didn't have flu and pneumonia shots, it would be a lot higher. And by the way, that's not necessarily a bad thing. In the pre-antibiotic generation, they used to call pneumonia the old man's friend.
Yep.
The old man's friend. So those are the changes in the evolution of death in America. This is probably the biggest change. This is just since 2000. People, where do they die? Where do they die? In 2000, 62% of people still died in a hospital. Call 911, grandma looks like crap. Doesn't matter that she doesn't want to go to the hospital and she's 115 years old, we still wouldn't call the ambulance. Because we didn't want to deal with death. That's something the doctor did behind closed doors. Like the old Marcus Welby TV shows. Then he'd come out, how'd she do, Doc? Sorry, big block doors behind him. She didn't make it. There's no reality to it. There's no closure. There's no humanness in that. So good news is people aren't dying in hospitals as often. Interestingly, they're not dying in nursing homes that much more. What's really changed is dying at home with hospice. Now, there are inpatient hospices that are common all around the country. It's sort of like a nursing home environment, but it's dedicated to hospice, and then you can have hospice at home. In northern Nevada, we've never had extended inpatient hospice or a big unit like Las Vegas would have. So most of the hospice in northern Nevada is either in the home or hospice can come to the nursing home. For that matter, the hospice people can come to the hospital and take over at that point. But the bottom statistic is really the most interesting. Hospice care in any setting over the last 15 years has increased from 10% to 44%. And I would argue, and I will argue through our talk today, that that's a good thing. That's not a bad thing. That's a very good thing. It's all a matter in how you use it or approach it properly. So, causes of death are changing. We're seeing different things we didn't used to see in the old days. And I don't know how many remember that song from all those years ago. Old song from the 1970s. Laid down the boogie and played that funky music till he died. So what are the aspects of death and dying that really frighten people besides the obvious, the fear of the unknown and the transition? Well, if you talk to most older people, those over 65, certainly those over 85, pain is the #1 fear. They don't want to be in pain around the time of their death, or even beforehand if it's a slow downhill run. And, talking about pain and other symptom care is very, very important. It used to be taboo to even bring it up, and especially for some of our parents, they don't want to talk about it. But it is important to talk about it and really try to find out what somebody's wishes really are and what they want to do. Anybody know the difference between palliative care and hospice? I have a definition I like to use that makes it a little bit easier. So hospice means you are going to focus on symptoms, and you're no longer really going to actively treat whatever the underlying disease is. So you're an old emphysema patient, you keep going to the hospital with pneumonia, you get IV antibiotics and intravenous steroids and all that. You say no more. You may get some oxygen because that could be a comfort measure, but it'll be comfort measures. You may get some morphine, you may get some Valium-like medicines, but you're probably not going to get antibiotics or anything like that. Palliative care is kind of an in-between. It's a little bit different. Palliative care really started to evolve for people with chronic, maybe terminal diseases over the long haul, but not terminal right now. Palliative care says, we're not going to stop treating the underlying disease, but we're going to focus on the symptoms. So symptom control will be our primary focus. And we're going to talk about what you want or don't want as far as invasive or aggressive things. Some you may want, some you may not. But we'll focus on the symptoms, but we still may treat the underlying disease. Good example to kind of clarify it for you. I like to use my mother, who passed away about a year ago. She was an old emphysema patient, smoked her 3 packs of Tarringtons a day for 70 years or whatever it was. And she was at the last stage of her life, 92 years old, she was in a nursing home. Now, she got a pneumonia. If she was a hospice patient, we would have kept her there, which we did, given her maybe some morphine or Valium-like compounds, a little oxygen if it made her feel better, and let nature take its course. If she was what we call a full code or full treatment, we would have transferred her to the hospital, put her on the IV antibiotics, put her on the IV cortisone. She wanted nothing to do with that. She was more in the palliative care realm. So what did we do? We gave her the oxygen. We actually gave her antibiotics, but not IV. We gave her the most powerful oral antibiotics that we could give her, and she got better from that on several episodes. She didn't want to go to the hospital. She didn't want to go on IVs. So she still got treated, the underlying disease, the breathing treatments. We gave her oral steroids instead of IV steroids. Whatever she could get in her hospital or nursing home bed without having to go back to the hospital. That's not an absolute, but that's a good example of palliative care. the focus was on her wishes and not giving up on the underlying disease, but treating it, what I would argue, within reason, based on what she wanted as far as how aggressive to be. Where hospice, she wouldn't have had any antibiotics or any of those treatments that could actually change the underlying disease. So communicating about illness and death ahead of time is critically important. It's also critically important to really identify that psychosocial support. Who's going to be there when you need them? Who's going to be there for mom when she really needs it? Some people handle death, obviously, a lot better than others. Some can get right down in the trenches and hold hands and give hugs and help people across their bridge to meet our Lord. Other people, it's exit stage left. Once again, using my mother as an example, she called me, a very practical woman. It was Saturday morning, about this time last year. She's down in the Bay Area. She said, "What are you doing?" I said, "I'm running some errands." She said, "Oh, I just want to let you know I'm on my way out." Kid you not, those were her words. In retrospect, she actually passed away. She died the next morning. So I said, "Mom, I'll be right down. I'll drive right down." She said, "I want you to fly." I said, "Mom, why do you want me to fly?" "Well, you'll speed and you'll get in an accident." I said, "Mom, you just told me you're dying." She goes, "I'm still your mother." True story. True story. So I got down there and we had about 20 people around that bedside all afternoon. Now when things started to get near the end, by about 10 p.m., it was down to about 5. And by about 2 a.m., I'm sorry, there were 3 of us. That's okay. That's okay. But you need to know, especially if you're looking at yourself or a family member or a friend that may at some point need hospice care at home, what's that going to look like and who's going to be the one to help? One of the reasons hospice fails is we don't communicate, the healthcare industry, we don't communicate well enough as to what hospice provides. And people get the idea that the hospice nurse moves in. The hospice nurse doesn't move in. They're on call, they'll come by, once a day, what it may be. They're not sleeping on the couch with you and doing everything. So that's very, very important to identify where those support systems are going to be. So communication, I like to say, is everything. Figured you'd like this one.
What's it say?
I don't know if you can see the little foot there. That's just brutal. So, palliative symptoms. Pain control, as I mentioned, is the #1 thing, especially in cancer patients. Also, even heart patients can get just intractable, hard to control angina. And if we're not going to be super aggressive, that can require very important and very aggressive means. But symptoms other than pain are also critical. Too often we ignore the side effects of the pain medication, which the constipation from opiate pain medications can just be absolutely worse than a disease. And many other things, including, and I would say especially, anxiety and the normal depression that somebody who goes through with a terminal illness. We talk a lot about grieving. If you have a terminal illness, it's normal to grieve for yourself. And you go through all those same stages of grief as you would grieving for somebody else. And that needs to be looked at. You need to look at sleep patterns. You need to look at abdominal pain, aches, pains, nausea, vomiting. Is it the pain medicine that's causing the vomiting? Is it the anxiety that's causing the abdominal pain or the vomiting? And that's all discussions that are best had openly and out front, rather than going behind a closed door and trying to guess what's wrong with the person or saying they've got their prescriptions, have a nice day. What do they say in the South? That dog don't hunt. I travel a lot down there too. So symptoms other than pain are always critical to address in a patient who's facing end of life. So pain management, as I mentioned, there's physical pain. There's also psychological pain. I heard the story yesterday. A parishioner came up to tell me after one of the talks. She had a friend that was hitting ERs all over the country with this terrible chest pain and abdominal pain, and they couldn't figure it out. And nobody bothered to ask about the fact that both her mother and a sibling passed away within a week of each other about a month ago. Think it's related? Maybe. Doesn't mean you ignore the symptoms, but if you can't find an obvious physiologic cause based on a disease process, it's often related to the depression, the anxiety, the worry, the fear. And that's just as important to address as pain or constipation or any other physical symptoms. So this is a common issue we run into at end of life. Even with nurses, unfortunately, sometimes, especially the young nurses. What's the right dose of a pain med for a dying patient?
The one that works.
That's exactly right. You're reading ahead.
Well, no, I'm a nurse, I know that.
That's right.
As doctor would order, titrate to effect.
Right. And this is a common issue because we develop naturally a physical tolerance to pain medicines. The more you need, the more you get, the more you need. And the problem we run into is there's still that little thing out there in everybody's head, oh, I don't want to get addicted, or I don't want my patient to get addicted. It's like, if you're not going to live,
Yeah.
who cares? Control the pain. And the common order that we will write is, even in the hospital, I'll write titrate to symptoms, not vital signs. Meaning, give enough medicine to control the symptoms. I don't care if their blood pressure is low. And you still see that. A nurse will go in and take a blood pressure and she'll say, I held the morphine. Why? Well, his blood pressure is 95. And I'm like, he's dying. So you can guess my quick resolution to that. I just discontinue the vital signs. Say, what should we do? I said, don't check the vital signs. Doesn't matter. Well, what if he stops breathing? I said, he's going to. Yes, you have a question.
You might be addressing this in the future, so that's okay to wait. But how do you answer the question for people that struggle with that in terms of, okay, how is that different than euthanasia? And,
Right.
I have actually a woman in our church who works in our grieving program and has said specifically accusing hospice of that. She's like, there's no way I'm going on hospice because all they do is they tell the family, start giving them the medicine, and nobody ever comes out of hospice alive.
You know,
Well,
that's not true. I've taken people off hospice a million times, and we'll get to that in a little bit too.
Okay.
I really have. And people often outlive hospice. And you're supposed to certify, I'll start with that, you're supposed to certify that the patient's going to live 6 months or less. And you sign this little form. And people get nervous about that too, because we're often wrong about predicting how long someone's going to live. So I always tell the medical residents and the medical students I teach, if you think they benefit from the service and they have a terminal illness, by all means fill out the form. And the way I like to tease them, I'll go up to them quite often and say, if you fill out that form and they live longer than 6 months, do you know what happens to you? They're like, what? Nothing. Fill out the doggone form. But your answer about euthanasia, it can be a very simple answer, which I'll give you, and then a complicated explanation, which I'll give you the short version. But this is a good time to mention it. It all has to do with intent.
Right.
It's all about intent. Notice I said titrate to symptoms, not vital signs. If your intent is to kill someone, that's euthanasia. If your intent is to relieve horrible pain and symptoms, and it shortens that person's life because they relax by an hour or two, but your intent is not to shorten their life, your intent is to relieve their pain. You're trying to give enough medicine to relieve their pain, not take it completely away. Notice I'm not saying that. You really never, almost never can take pain completely away. You can take the edge off. So you may take the pain from a 10 to a 5, or an 8 to a 2. You're rarely going to take it to 0. If your goal is to make them comatose and unresponsive, so there's 0 pain, that's bordering on intent to kill. So often people will try to titrate vital signs, assuming, and sometimes this tightrope isn't there, assuming you can get the pain down well enough, and families really appreciate this, get the pain down well enough that the patient, maybe they're sleepy, but they're arousable, and they can still have a meaningful interaction with friends and family at the bedside. And that's really what we try to shoot for. Yes, Kurt?
Brian, when you and I were cutting our teeth, do you remember the time when the USCCB opposed us for this?
Oh yes. They considered it euthanasia right out of the gate. But that's why it's also a learning experience. You know, lay people, including our bishops, they have to learn just like we have to learn as medical science evolves and the knowledge of how to treat these patients evolves, how it fits into Catholic teaching. I'm not suggesting for a minute that teaching is different. No, it's not. The Catholic teaching is the Catholic teaching. But how we interpret what we can or can't do does change with regard to that teaching based on what we learn over time and how to best care for these patients. And that's where some of the confusion comes in. So the short answer is, if your intent is not to kill them, then it's not euthanasia. If your intent is to lessen their suffering, not in the sense of I killed them early, I lessen their suffering, that one doesn't count, that's euthanasia. But you just want to take the edge off their pain. They're screaming in bed, and their blood pressure's a little low. You know what? You give the medicine anyway. You titrate to the symptom, not the vital sign. This again is an actively dying patient. This is not someone who's not actively dying with just a chronic illness. Okay, but that's the short answer. It's all about intent. So here's a better medicine, by the way. This is also increase the doses tolerated. This is one of my favorite things I've ever found. So the best medicine for humans is love. Someone asked, what if it doesn't work? The physician said, increase the dose. So what's the law on this? And this is important, because physicians even today are so frightened about being accused of actively killing someone. And I tell you, we still struggle, especially with our medical residents, our interns, our medical students, on doing the right thing with a terminally ill patient because of their own fear. Back to that, let's hold the drug because the vital signs are low, and someone who's going to be gone by morning. That just doesn't make a lot of sense on any level. So what is the criminal law with palliative care? You know, doctors do fear legal sanctions when they give very high dose opiate or painkiller, narcotic pain medication for dying patients. This is getting better, but this still exists out there. You will run across physicians that are hesitant to refill your mom's Percocet even though she's dying, and she's going through it faster because she has tolerance to the medicine now because she needs it more. And that's very legitimate. Anxiety, of course, all physicians are anxious towards the legal system. I remember the 1970s, my dad, first malpractice crisis in California, he's an old surgeon. He had a bumper sticker on his car that said, become a doctor and support a lawyer. And of course, my oldest sister became an attorney, the oldest of five. So she called him the quack, and he called her the shyster, and it was just a very interesting relationship. So, you know, looking at this a little deeper, state laws and regulations vary, but what is interesting is over the past couple of decades, there have actually been physicians in this country brought up on every one of these charges, all the way down to and including first-degree murder in caring for a terminally ill patient. So this fear is real. The good news, it's getting much, much better. The bad news is we see the culture of death probably going too far the other way with the widespread acceptance of assisted suicide. And we're going to get into that in some detail a little later in the talk. So just file that one away for now. So non-pain, the hardest thing is, as I mentioned, anxiety, worry, depression. What are your biggest fears for yourself, for your family, for those you're leaving behind, and someone who's terminally ill? And I would argue that most healthcare personnel, not all, are very ill-equipped and ill-trained to deal with these issues. We have some good people in the palliative care and hospice industry. We still need a lot more providers trained in how to recognize and deal with a lot of these other issues that come up through the death and dying process, and even in the pre-planning process. So research is limited, but it's getting better. And you know, this is kind of the offhanded way sometimes I think we approach these things. You see the guy with the arrow through his head, right? Offhand, I'd say you're suffering from an arrow through your head. Just to play it safe, I'm going to order a bunch of tests. We had a running joke in the trauma part of Renown over the past few years. We said, this day and age with the medical legal way we practice, if someone came in after having their leg amputated by a train, we'd get an orthopedic consult and an MRI before we'd confirm the diagnosis. Yes, the leg really isn't there. So, now this is really a tough issue, and I'm going to spend a little time on it. There is a lot of misunderstanding when it comes to nutrition and hydration in death and dying. If you really want to understand this well, not only from a practical standpoint, but especially from a Catholic social teaching standpoint, and Catholic doctrine, first thing you have to do, and I can't emphasize this enough, separate in your mind right now an actively dying patient, meaning you're going to be dead today, tomorrow, next week, 48 hours. You're calling the kids, time to come. Dad's on his way out. Mom's on her way out. An actively dying patient from someone who is not at the terminal phase of a terminal illness. So to say you have 5 years to live, that's not what I'm talking about when I go into the subject. I just gave you 3 years to live, which, by the way, as I said, we're always wrong. And we'll get into that too. So this is someone who is at the end stage of cancer, of heart disease, of emphysema. You're rounding up the family members, you're circling the wagons. It's the end. That's what I'm going to refer to when I go into this section. I'm not talking about Terry Schiavo. Terry Schiavo was in a persistent vegetative state. She was starved to death. She died of dehydration and malnutrition. That's a totally different thing. Catholic social teaching would never allow you to pull tube feeds or fluid, water, from a patient like Terry Schiavo. She was not in an actively dying process. Now, I'm going to flip this on you. What do you think happens when you are actively dying? So you're at the very, very end. You two can't answer. You can't answer either. What happens?
You stop eating.
You stop eating. And you stop drinking. In the forest primeval, the Lord was still around. When it was time, like the ancient Hawaiians, maybe you climbed up the hillside, you curled into a ball, and you went to sleep. That's a natural death. What does Catholic teaching tell us? From natural conception to what? Natural death. Not artificial death. Natural death. When someone is actively dying, giving them artificial nutrition through a tube or giving them IV fluid and calling a comfort measure actually prolongs their dying and usually adds to their suffering. Giving IV fluid and artificial nutrition at the end of a terminal illness extends the death process beyond what would be natural and adds to their suffering. So they're going to suffer longer because you're keeping them hydrated artificially. The other beautiful thing, and the medical people in here know this, when the body is shutting down, and okay, let's say we're not giving them food, they can't even eat, we didn't put in a feeding tube, but oh, give them a little IV fluid, we don't want them to get dehydrated, and it's the very end. If you don't give the IV fluid, which is the natural way, the kidneys are one of the first things that begin to shut down. And that's not painful. It's not painful at all. They actually build up a normal toxin that we eliminate with our urine called blood urea nitrogen. And the patient goes into a state we call uremia. Uremia, blood urea nitrogen, acts like a natural narcotic. It's almost like a natural morphine. It actually can help reduce pain. It makes you a little sleepy, and eventually, like the Hawaiian that would climb the hillside, you just go to sleep. As natural as anything. Guess what IV fluid is the best treatment for? Uremia. So you're going to keep them awake and screaming, especially if they're in pain, by giving someone at the very end IV fluid. You will add to their suffering. Very important, again, I can't emphasize it enough. I am not talking about someone who's not at the end. I'm not talking about someone who's terminal in 6 months or a year. I'm not talking about a persistent vegetative state. I'm talking about grandma has circled the wagons, the family's around, and we're holding vigil, this is the end. That's a time not to give food and not to give IV fluid. Yes?
What happens if they sign a do not resuscitate form?
You mean at the end?
Yeah.
That actually would be the typical case. And if it's very interesting. Most people, when they're terminal, will go ahead and fill out, and we're going to get into advanced directives, fill in a do not resuscitate order form. Which again, resuscitating someone, which is the code blue thing you'd see on TV, is really meant for a younger, healthier patient. If you have a code blue called on an adult 50 or older in the hospital for any reason, what do you think the odds are you get them back?
Not good.
About 10%. But here's one you don't hear. What are the odds that person will leave the hospital alive? Less than 1 in 1,000. And in fact, when you have a terminal patient, truly terminal, who wants to be a full code, we can, in extreme circumstances, call coding that person fetal care. Like any procedure in medicine, if you think about it, you have to weigh the risk versus the benefit. CPR is a procedure. If the risk is you're going to break their ribs, burn their chest, and beat them up, and the benefit is they're going to die anyway, there's no point in doing the procedure. So, but we will get into the DNR type stuff in some detail coming up. So, but at the end of life, don't feel like you have to give IV fluids. In that sense, you're actually treating yourself and you're hurting your loved one. You're hurting your loved one. So this is some other interesting, slightly longer term in the very end. 51% of patients with dementia had feeding tubes placed during their terminal hospitalization. So Alzheimer's type patients. What did I tell you earlier about how dementia patients die?
They aspirate and get pneumonia and die.
So
That's
what's the
just to
point?
prevent them from getting aspiration and pneumonia.
Which, guess what?
Prolongs their life.
It actually doesn't really work long term in preventing aspiration, the latest studies show. So it's contrary to what we've always taught, since, as Dr. Carlson said, he and I were cutting our teeth. Turns out long-term feeding tubes in nursing home patients, they had a slightly higher 1-year death rate from aspiration pneumonia than the patients without the feeding tubes. Very interesting. Nobody expected that, but it is. So as I like to say, not eating and not drinking is a normal part of dying, not the cause. So someone with advanced dementia, Alzheimer's, you're worried they're going to aspirate. Do you have to put a feeding tube in? No, you don't have to. What's the natural way that they would go? They would eat, enjoy it, aspirate, get pneumonia, and die. The old man's friend. You can actually write an order, as physicians we do this all the time, that says eat for pleasure. In other words, we're recognizing the risk that you will probably aspirate. You have advanced dementia. You're near the end. Why am I going to put in a feeding tube and now deny you the ice cream or the macaroni and cheese or the hamburger you want? You know, I'm going to give you your last supper, whatever you want, and I know it might go down the wrong pipe. You're at the end. You're at the end. And that's a natural death. It's because the end point will still be the same even if we put in the feeding tube. And this is advanced Alzheimer's because they lose their ability to clear their throat. So IV fluids, again, not a comfort measure. And this, I think of my parents when my mom was getting older. This definitely would have been my father. I just really love that. That was the old World War II generation. So it brings up the question, and this is, the discussion's good because it brings us full circle to really the big question. Is it legally and ethically acceptable to withdraw artificial nutrition and hydration? I love this quote. This is from St. John Paul II when he visited a hospice in Italy in the late 90s. Back to natural conception and natural death. Artificially prolonging life is just as morally reprehensible as artificially taking. Fascinating. Bet you didn't see that one coming. Often, I use this quote very often in the hospital, and you can guess where this will come from. I'm not trying to be flippant, but I love it. I'll have a patient's family say, "Oh, well, Grandma has to be a full code. We're Catholic. It means you have to do everything." And then we have the little talk, same talk you're getting today. I say, funny you should say that. I'm Catholic too, and I argue we don't have to do everything. Depends on the circumstance. Depends on the circumstance. Now, where do you cross the line? And we'll get to this with assisted suicide. When someone who has no real reason to fear for their life, or that they're in the terminal phase of a terminal illness, starts refusing what we would consider ordinary measures. Not extraordinary, like a code blue. They could still not want a code blue. Statistics are really bad coding old people. But they could say, I don't want antibiotics, I don't want anything. Let's just not do anything for my very treatable disease that's not terminal. That is where you start getting the question of, if you're refusing ordinary measures, then that does violate, on a self level, Catholic teaching, your responsibility to take care of yourself and your own body as the temple God gave you. So when you get into these discussions, the other key pearl, always separate ordinary from what we'll call extraordinary. And of course, the begging question is, how do you know what's ordinary versus extraordinary? Well, it depends on the circumstances. In a 10-year-old trauma patient, I would call code blue an ordinary measure. And an 85-year-old with advanced colon cancer, I would call a code blue an extraordinary measure. And again, those are extremes. So you really do have to have that open communication and that discussion. So, this is about the study I was telling you about. It's very fascinating. Tube feeding made no difference in survival for nursing home residents with total dependence for feeding compared to those who did not receive tube feeds. So of 5,266 nursing home residents with chewing and swallowing problems, those with a feeding tube actually had a higher one-year mortality. Kind of turns everything on its head, doesn't it? So, what's the physician attitude? I tell you, we struggle with this all the time, especially with young physicians, and some physicians their whole career. As you could guess, training physicians are very uncomfortable, just like we all are, discussing death and dying issues or withdrawal of feeding and hydration. They don't want to be accused of euthanasia. And they're often not as educated as we would like with regard to what you've already learned today about intent. If your intent's not to kill someone actively, that's not euthanasia. And tube feeds, because of that, is usually the last thing withdrawn. And this is a really scary statistic to me. It is getting better. It's a little bit dated now, but in the late 1990s, as of that date, 42% of doctors and nurses still believed artificial nutrition and hydration should be continued, even at the very end. Well, from what you've learned today, that's kind of a sad commentary. We need to do better in our education. I think we are getting better in our education. I can tell you the other thing that you'll face in the hospital, I see this all the time. If I'm a physician, new, young, old, trainee, and I'm uncomfortable with death or dying, what's the easiest thing for me to talk about when you have your colon cancer metastatic to the liver and you have this abscess and all these things? What am I going to talk about? I'm always going to talk about what's next. What's the next technical thing I can do? You know, we can put this drain in here and we're going to put you on these IV antibiotics. If that drain doesn't work, we could try to open it up. Notice what's missing here? I haven't asked him if he even wants this. Maybe he does. Maybe he says, you know what? I want to do everything to get every last second of every last minute, no matter how miserable I am on this earth. By the way, who do I get that most commonly from? Take a wild guess. What? No, kids usually go into peace very fast.
Spouses.
What?
Spouses.
Mothers.
What kind of patient? I'll give you a hint. I'm not looking for a diagnosis. I'm looking for something that has more to do with value system.
An atheist?
Atheists. Atheists are the most likely to always want to press on no matter what. You know, think about it. If you don't believe in anything, man, the great abyss, the darkness, whoo, I wouldn't want to be facing that either. Actually, people with strong faith systems, when you explain the details of this versus that, are usually much more likely to come to peace with the decision making and actually make more reasonable decisions, in my opinion, most of the time. In fact, in the grief talk, which I guess I'm doing a little bit later, this goes not just for grieving for another person, but it also goes with, as I said, grieving for yourself. As you do grieve for yourself if you have a terminal illness. People with a strong faith go through the grieving process in a much more healthy way, and they recover from it much, much faster and more completely. Notice I didn't say totally. You never recover totally from grief. Much more totally than non-believers. And that's not just opinion or conjecture. That's been looked at in study after study after study. A strong faith system is the single best predictor of dealing with grief or loss well, as compared to anything else. And it makes sense. We know there's a light at the other end of the tunnel. You know what? I don't necessarily want to go yet, but if that's what he's saying, then okay. So, now this is, I like to say, this reminds me of my medical residence when a patient wants to have a talk about their own death. Kind of a scary thought. So, this is that order I told you about that I think is very, very useful. And in somebody who has a high risk of aspiration, but is in a terminal illness or the terminal phase of an illness, be it an Alzheimer's patient or somebody else. Well, you can write an order, and you can do this at a hospice level, you can do it in the hospital. Eat for pleasure. In other words, we're not going to restrict what you can or can't eat based on the worry of you not digesting it, aspirating it, that kind of thing. And it has, obviously, food has incredible cultural and symbolic significance. Breaking bread, we all know what that's all about. And being able to do that at the end, even if part of it goes down the wrong pipe, you know what? That's okay. That's still